go ahead and get started. My name is Edith, and we welcome you to our July topic. It's called Best Practices for Venous Sinus Stenting. Are we over-treating or under-treating patients? We'd like to welcome our guest speaker, Dr. Athos Patsalides. We are honored to have you today. He is an interventional neuroradiologist, and he is a professor at the Department of Neurological Surgery at Northwell Health. He has pioneered novel treatments for idiopathic intracranial hypertension and pulsatile tinnitus. And we have Dr. Pierre Gobin, who is a neurointerventionalist at Weill Cornell Medicine in New York. And we are welcoming you both. And I will go ahead and mute myself and allow for both of you to start, and he'll slide share and we'll go from there. See you in the.
Good evening, everybody. I was very happy to see those two pictures that make us both look younger here, much younger. We'll share my slides. Let's see. I hope you can see it, right?
Yes.
Very good. So just by this is an important topic to me. I based my academic career on venous sinus stenting. And second most important thing today for me is that I'm presenting with my mentor, Dr. Gobin, who trained me, and I worked with him for 11 years at Weill Cornell. So it's special moments. This is like essentially a journey of how I saw venous sinus stenting involved and how I participated in this, and my thoughts on its future directions. So I'll divide this talk into what we learned for the last 20 years that venous stenting has been available. Can we expand indications? Can we improve outcomes? And what are the future directions? So over the last 20 years, I think the first case report for venous stenting was in 2001 or 2002. We learned that venous sinus stenting, specifically for intracranial hypertension, is an effective treatment for papilledema. It's an effective treatment in terms of normalizing intracranial pressure. It does improve the quality of life of patients. It does resolve the pulsatile tinnitus caused by venous sinus stenosis. We also learned that the rate of treatment failure is low, but not very low. And the risk of treatments are very low, but not zero. Back in 2009, we started with my exceptional colleague from neuroophthalmology, Mark Dinkin at Cornell. We started the first clinical trial of venous sinus stenting in the United States. And this was focused on patients with severe papilledema and severe vision loss that have failed medical management or prior surgery with shunt or optic nerve sheath fenestration, or if they presented with fulminant presentation. And what we've shown is that there was a significant improvement in the degree of papilledema and the degree of visual field loss. These are the results from that initial study in 48 eyes, 24 patients, 48 eyes with papilledema and significant vision loss. And we have shown that in every patient, there was at least one eye that improved significantly. On average, there was a major improvement, -10 deviation to -4.7, closer to zero for any patients who are listening. Closer to zero is normal. So -10 is very bad, and -5 is significant improvement. And there were some patients that did not show improvement in one eye. This was atrophic already from severe papilledema for years due to unsuccessful earlier treatment, but at least one eye in every patient had significant recovery. And in the vast majority of eyes, the papilledema either improved significantly or resolved. The blue line is the papilledema before treatment, and the orange line is the papilledema after treatment. And you see the average pre-stenting was 2.4, and the average post-stenting was 0.5, which is a major improvement by any means of neuro-ophthalmology criteria and standards. A little later, we looked at the effect of venous stenting on intracranial pressure, and we studied this in 50 patients who had spinal tap with us before stenting and at 3 months after stenting. And we have shown that the average opening pressure on a spinal tap decreased from 37 before treatment to 20 after treatment. And this was, again, the post-treatment spinal tap was at 3 months after stenting. At the same time, we looked whether...
Can I interrupt here, Athos? What is the normal CSF opening pressure?
Well, that's, I mean, I would say, below 20, we consider it normal in general for the average adult. Above 25 is abnormal. And between 20 and 25 is that gray area that has to do with body habitus and some subjectiveness. So 20 is the upper limit of normal in reality. We saw whether medication usage was the factor here, but actually we saw that at the time of the post-stent spinal tap, there was 70% less Diamox being used by the patients. The majority of patients were actually off Diamox completely, and the rest were taking less, but on average, there was 70% less Diamox usage. And in terms of weight gain, we saw that there was no significant weight loss to explain or to confound these results. In fact, most patients either had an unchanged weight or a very small weight gain. And unchanged weight, I believe we defined it as within 3 or 4 pounds from the pre-treatment weight. So the weight was not a factor. Medication usage was certainly not a factor, and the only difference in this situation was the stenting procedure. We also had looked at the headache and quality of life before and after stenting in patients with IIH. We used a questionnaire from the IIH Foundation that is relatively simple, 0 to 5 answer for 14 questions. And we did this serially, during multiple follow-up visits. And we showed that the mean quality of life improved. 0 is best. And it went from 48 to 20 after stenting. So we saw a significant improvement in quality of life for patients after stenting. But the reality is that headache remains a problem after stenting for many patients. This is an excellent paper from a group in England that collaborates. They looked at the possible trigger factors for persistent headache after normalizing intracranial pressure in patients with IIH. And these are all patients that they looked at, patients who had papilledema before treatment. And after treatment, this was medical treatment or surgical treatment, the papilledema had resolved. So there was good indication that there was significant improvement of intracranial pressure. But at the same time, in many of these patients, the headache persisted. And what's interesting is that before normalizing the intracranial pressure, the headaches were often what we call typical of high pressure, like episodic headaches related to body positions, related to the timing of day, but certainly more episodic. And after treatment, there was a change in the characteristic of headache, which was more like a constant headache with spikes, more like a migraine with exacerbations rather than the typical high intracranial pressure headache. And they identified several risk factors for why headache persists after intracranial pressure normalizes. And these are the factors in the, I don't actually, can you see my, sorry. So they saw the history of previous migraine or family history of migraine, medication overuse. I think this is a big one in patients with chronic patients with IIH. Depression and anxiety is also a big factor in chronic patients with IIH. Obesity and obstructive sleep apnea, all these factors predispose patients to have chronic headache even after what they would call successful treatment in terms of high intracranial pressure. And there is more work that is being done on this, and certain medications, a lot of migraine, the new generation of migraine medications are being used for these patients successfully. And Botox is like another treatment that seems to be working well, and I'm hoping that there's more to come, because I think this is a problem that we see more and more. In terms of pulsatile tinnitus, we have shown in our group that essentially in all patients or almost every patient, there is resolution of pulsatile tinnitus after stenting. And this is something that, you know, we weren't treating patients with IIH for pulsatile tinnitus. At the time, we were focusing on visual problems and papilledema, but we saw over time that we noticed that was like this effect of treatment that, you know, obviously has become very important in terms of quality of life on patients. And again, this is specifically for IIH patients. There is a failure rate with venous sinus stenting as in every therapy. And a couple of years ago, we had looked at patients that were treated with venous sinus stenting for documented IIH that were followed for a long time, at least 18 months. So essentially, this was like the first group of patients that I had treated, and we had up to 8 years follow-up at the time. And we defined treatment failure as having combination of ongoing headaches despite consistent with elevated pressure, persistent papilledema, persistent increased pressure on spinal tap, and or new stenosis on MRV. And patients need to have 2 of these 4 criteria for us to determine this as treatment failure. So this was not necessarily the patients that we had to necessarily have to be retreated, but this was how we defined treatment failure. And the reality is that these patients eventually were retreated either with stenting or with shunt. So the treatment failure in this initial group of patients was 14%. And again, these are long-term results. These are like at least 18-month follow-up. So I think these are relatively accurate in terms of the longevity of treatment for IIH patients. And one patient went straight to shunt, and the other 10 patients were treated with repeat stenting, and 2 of these patients ended up needing a shunt after recurrence after the second stent procedure. So overall, 4% of patients initially treated with venous stenting had to be treated with a shunt. And I think that number in my practice, I think is still accurate. Certainly 2 or 3%, 4% of patients may need long-term shunting after stenting, at least from, you know, based on the current treatment options that we have.
Can I interrupt here, Athos, again? So who are the patients that you stented? The patients that are not doing well, still have high ICP, but you don't see a recurrent stenosis? Is it those patients? Or a new stenosis, I mean?
You mean which patients that did not stent, you say?
Yeah, which patient required shunting?
I think the patient who required shunting initially, I remember this patient very well. At the time, the recurrence was in the superior sagittal sinus and was very early on in our experience. And I thought that this was uncharted territory, and I had a discussion with her, and she opted to have the more established treatment. The other patients that required shunt after stenting, it was patients that we treated, and then new stenosis developed, So these are patients with structural deficiency in the wall of the dural sinuses that are prone to collapse and stenosis, more like a global collapse rather than like a focal narrowing. This is a little busy slide. This is from the same paper and the same analysis, but certainly what we showed that was the only factor in that series that, correlated with treatment failure was very high intracranial pressure at diagnosis. So for every centimeter of pressure on pre-treatment spinal tap, there was a 6% increase in treatment failure. And I think that says that there is a likelihood of patients that have very high intracranial pressure at presentation, they are more prone to this kind of global diffuse venous sinus stenosis, or more prone to having a structural problem of the venous sinuses that predisposes them to progressive stenosis. I was very surprised to see that the type of stenosis and the gradient across the stenosis was not correlating with the risk of treatment failure, but that is what our analysis has shown at that time. So the only factor we found was higher opening pressure predisposes to treatment failure. In terms of risks, I think we are fortunate that we are able to treat patients with a very low risk procedure, but the risk is not zero, and there is mortality. There's also risk of disability, and these events, we see them in the literature or we hear about them. They're fortunately very rare, and I think that's why experience and education and thoughtful approach is very important. What's important for us to, as a group of physicians who perform these procedures, and for our patients to know, is that complication in this procedure is difficult to manage. And yes, the shunt procedure is prone to infection and revisions, and that's well documented. And the stent procedure has, on average, less complications in terms of likelihood of complications, but the severity of complication is not negligible. So we have to be very careful, and we have shown this in a meta-analysis of every published series involving stenting or shunting, that the risk of complications from shunt is higher, but the severity of complications from stent is worse. So this time we have to be very mindful and always think about ways to improve this procedure and make it safer for our patients. In terms of expanded indications, based on the work from the IIH population and understanding that venous stenosis is very effective in treating pulsatile tinnitus, then we looked into patients who have pulsatile tinnitus alone due to venous sinus stenosis without the other features of IIH. In other words, they have normal intracranial pressure, they don't have papilledema, and they don't have high pressure headaches, and these patients often suffer purely from the disability having the pulsatile tinnitus, the impairment in their quality of life from pulsatile tinnitus. There was a couple of there's at least 2 papers. I think that's another one that I don't mention here. But as our group and the NYU group that showed that analyzing clinic visits with pulsatile tinnitus, patients showed that venous sinus stenosis was overwhelmingly the most common cause, at least in the patients who seek consultation. And if we look at younger patients, and especially female patients, it's probably like 80% of pulsatile tinnitus patients in women younger than 40 years of age is probably related to venous sinus stenosis. So it's a common problem. And obviously we see this more and more. We had done the first clinical trial on this topic. It was 42 patients with venous stenosis, normal neuroophthalmological exam. Patients had a spinal tap if there was a history of headaches to confirm that the intracranial pressure was normal. Obviously, if it was not normal, they would not belong into this group. We documented a gradient of at least 4 millimeters of mercury across the stenosis. And in these 42 patients, again, this was a prospective study, which we did right before COVID, actually. And we have shown that there is resolution or near resolution of pulsatile tinnitus in 98% of patients. The one patient who did not have improvement, she had a second source of the pulsatile tinnitus, which was a jugular bulb diverticulum, which I treated then and at the second time. But the summary is that this treatment is exceptionally effective for carefully selected patients with debilitating pulsatile tinnitus, which opened up, a completely new indication for this procedure.
I have a question from the audience, Athos, about pulsatile tinnitus.
Mm-hmm.
The question is, if someone has 70% venous sinus stenosis and manageable pulsatile tinnitus, do you stent?
Yeah, I think that's a good question, and I hear this very often. And I think patients who, I have these monthly webinars for patients, and I say this a lot. Venous sinus stenosis by itself is not an indication for stenting. Without debilitating symptoms or without significant symptoms of IIH, there is no need to have stenting because venous stenosis exists on an MRI scan. If the pulsatile tinnitus is manageable, you can continue observation and intervention later if pulsatile tinnitus worsens. There are patients who have manageable or mild pulsatile tinnitus for years, and then it gets worse. And I saw many patients like that today. There are patients, I think that's a little less common, but we see that also patients who have pulsatile tinnitus for many years without headaches, without papilledema or visual complaints, who develop eventually symptoms of high intracranial pressure. So there is a chance that things will progress. There is a chance that patients with pulsatile tinnitus may experience worse pulsatile tinnitus over time, or patients with pulsatile tinnitus may experience the full spectrum of symptoms of high intracranial pressure eventually. But it's difficult to know what the likelihood of that progression is. And these patients need to be monitored and intervened upon if it becomes necessary. But having 70 or 80 or 60% stenosis on MRV does not necessitate stenting. I will also say that I think we're very limited in cross-sectional imaging, and even with traditional angiography, to assess the degree of stenosis in venous sinuses. These are not cylinders like the arterial system. These are irregular shaped veins or blood vessels. We're using intravascular ultrasound a lot these days, and we're comparing the degree of stenosis on intravascular ultrasound versus traditional angiography versus MRI, and the results are very different. So what looks at 70% on an MRV or a CTV or an angiogram is not necessarily that accurate. That's why these decisions should not be based only on degree of stenosis or even the presence of stenosis. They should be factored in with the patient's symptoms.
But if you have a gradient, then that's a criteria to say that the stenosis, I mean, that the sinus is not normal, that the stenosis there is something wrong with it, no?
That's correct. But again, let's say a patient has mild pulsatile tinnitus. I would not even do angiogram on this patient. I mean, if you don't need to you need to do a procedure, you don't need to measure gradient if the symptoms are very mild and manageable, because that's not going to change the way I will approach this patient. I will still monitor this patient, and I will do all these measurements at the time of treatment, or to confirm whether treatment is necessary. Let's put it this way. But I will not base the need for treatment. I guess what I'm trying to say, I will not base the need for treatment based on the presence or the degree of stenosis alone. And I think this is, I see that a lot these days, and I think it's not the best practice. We try to understand what predetermines or predisposes patient to have venous stenosis with IIH and venous stenosis with pulsatile tinnitus alone. And we looked at features on MRI scan. We looked at the type of stenosis. We looked at the length of stenosis. And what we correlated this likelihood is that the presence of a long segment, what we consider like as an extrinsic stenosis, is predominantly seen in patients with IIH. And the short segment intrinsic stenosis is predominantly associated with pulsatile tinnitus. And this is not like one-to-one. Again, it's higher likelihood for each group, and there is some overlap, but this is the analysis we had at the time. And other factors like, having an empty cella, for example, or having tortuous or marked optic nerves has some input, but not as strong. So the type of stenosis helps correlate with the patient's symptoms, and that's an information that we offer out there. And this is an example of predominant. This is from the same publication, like a long segment stenosis, the brain parenchyma compressing the vein against the skull. This is predominantly IIH population versus the more focal stenosis, intrinsic, like an arachnoid granulation, like this filling defect in the venous sinus, more associated with pulsatile tinnitus. Again, there is some overlap. This is not 100%, but it's a good correlation. More recently, actually, I think last week, with Dr. Dinkin and I published a paper that incorporates all the experience, all the publications in relating to venous stenting and IIH until like a few months ago. And this included either relatively large case reports or retrospective or prospective studies. There was like a little more than 1,600 patients in the literature, and we analyzed the results in terms of effectiveness in symptoms, papilledema, and I will go through this quickly. But this is like a typical for our patients on the call. This is a typical presentation of a patient with severe papilledema. This is the appearance of the abnormally swollen optic discs on ophthalmological exam. This is the thickening of the optic nerve on the test called OCT, what is called the RNFL, retinal nerve layer thickness. And this patient on the top row was at presentation. On the second row, there is no significant change. This is after maximal medical management. At the same time, the vision loss is worse, -15 compared to almost -5 a few weeks before, and -5.5 compared to -4 a few weeks before. So no improvement in papilledema or optic nerve swelling, but worsening of visual loss during maximal medical management. And then after stenting, we have normalization of the papilledema and the optic nerve disc. No, essentially normal appearance on OCT, and significant improvement of visual field loss. This is like a typical story of a patient that we would treat with severe papilledema and vision loss. These are all the studies that mentioned effect on opening pressure before and after stenting. So the total is 800 patients, and the numbers here are the average pressure recorded in each study before treatment, and in blue, and after treatment in orange. And you see some papers are like 1 patient, 10 patients, 20 something. I think this is the paper I mentioned earlier with 50 patients from our group. But on average, we have a significant improvement of pressure from 33 to less than 20 before and after stenting. Again, these are heterogeneous studies grouped together, but there is some value in these results when you see them in large numbers. Then we looked at symptoms, improvement or resolution or unchanged symptoms. And we see, for example, starting with headache, that there was like reported outcomes in 1,100 patients, again, multiple different heterogeneous studies. And there was improvement or resolution of headaches in about 80% of patients, and no improvement or worsening in 22% of patients. So there is a significant number of patients that still suffer from headaches after stenting, and we need to focus a little more on this with our neurology colleagues, how to improve their quality of life. In terms of pulsatile tinnitus, I'm a little surprised to see that across the board there is almost 18% almost 20% of patients with unchanged pulsatile tinnitus after stenting. This is certainly not the experience I have and I published, but this is what the data show across different studies. And then in terms of visual symptoms, the majority of patients have visual symptoms, means blurry vision, or any impairment of vision. That can include floaters, for example. So it's a little bit of very broad term, but we try to lump as much studies together as possible. But again, the majority of patients, they have significant improvement of visual symptoms. Diplopia universally resolves, and transient visual obscurations in 80% of patients were recorded as being resolved. So this is a good overview, I think, of how improve IIH symptoms after stenting. And again, the problem we have is with persistent headaches. Papilledema was resolved or improved in 85% of patients or 84% of patients. So major numbers, major outcomes in terms of papilledema. And this is the RNFL before and after treatment that goes along with the improvement of papilledema, again, significant change in the optic nerve thickness after stenting. That again goes along with the improvement in vision and papilledema. In terms of vision loss, again, based on the papers that reported visual outcomes, there is a significant change from -7.3 to -4.7. So significant improvement in vision loss in almost every paper or every study that included this variable in their outcomes.
I have two questions from the audience, Athos. One is from a neuroradiologist who has a patient with IH, papilledema, partially improving on Diamox, still headaches, and the MRV is showing transverse sinus hypoplasia. And this neuroradiologist is wondering, how do you differentiate stenosis, where you may stent, versus sinus hypoplasia?
Well, there is no, there's no fixed criterion. You have to obviously, if one side is hypoplastic, the other transverse sinus has to be significantly larger, or then there has to be an occipital sinus or two occipital sinuses. I mean, this is something that is not very common, but it exists. That the majority of drainage is via occipital sinuses, and these are amenable to stenting also. I think it's a little more complex to do occipital sinus stenting rather than transverse and sigmoid sinus, but it's certainly feasible. So in terms of hypoplastic versus not, I think you have to judge based on the contralateral side. It's a little bit of a, how can I say this? It's a relative decision, but if both sides are hypoplastic, then there has to be something else, like occipital sinuses. If there is stenosis, if one side is hypoplastic, and the source then you expect to have significant venous stenosis on the dominant venous sinus on the contralateral side. So without seeing the MRV itself, it's difficult to say more, but I'm happy to I'm reachable by email or phone if I'm happy to review these scans.
I have another question. A patient who doesn't have typical IH, but in this example, an empty cellar, tinnitus and headaches, is there benefit in stenting stenosis of a transverse sinus?
I mean, I was going to talk a little bit about this later, but I think it's a good introduction to the next part, and the answer is this is primarily driven by symptoms. If there is debilitating pulsatile tinnitus that correlates with the venous stenosis, then the indication to treat is that if the patient suffers from pulsatile tinnitus. The empty cella itself is, it's an imaging finding that over time we realize that it's less and less associated with high pressure and more associated with venous stenosis. There's some association with the lymphatic drainage. I think it's a little elusive as to truly what this means. Personally, I don't give much significance to empty cella, other than it makes me think of the possibility of the patient having venous sinus stenosis if I see this on an MRI scan. And again, it has to be in the appropriate clinical context. But yes, treatment for pulsatile tinnitus with venous stenosis is the study that we did a few years ago that I mentioned earlier. And it's something that we practice a lot in the appropriate patient. No question. So can we improve outcomes? Can we make this a better treatment? And one is need for better devices, and the second is need for better patient selection, or I'm not sure better is the right term, but more accurate patient selection. Let's put it this way. I'm not going to go into too much detail about this because we may have another discussion, but to date, we all know that there is no stent designed, approved stent designed specifically for venous sinuses. And we all use off-label carotid stents or venous stents, but certainly off-label use. The majority of stents that we use are precise, Pro, wall stent, or silver stents, and they have certain shortcomings. They're stiff, difficult to deliver. They often require intermediate catheters. They need a lot of support to be advanced. They often overstretch the venous sinuses, which can cause tear or dissection of the sinuses, can affect the cortical venous flow, draining into the venous sinuses. They are generally short, so we need to use more than one stent. They are stiff, so they often irritate the venous sinus at the edge of the stent, and they are unnecessarily strong in terms of opening the narrow vein. They have what is called very high radial force, which can lead to dural stretching and pain after the procedure for the patients. There are patients who develop trigeminal neuralgia after stenting because their stents were like oversized and overstretched the venous sinus and caused, they resolved the IIH, but then they caused constant irritation to the trigeminal nerve. So these stents, we use them, they work well to some extent, but they are not ideal. Obviously, we'll know river stent has been studied. The clinical trial is closed and the results are being reviewed. It's a first stent specifically designed for venous sinuses, self-expandable stent with large open cell type that adapts to the shape of the venous sinuses, decreases the risk of deformity of the cortical veins and the compromised flow, and has like a smart design in terms of being softer in the proximal and distal ends, but stiffer in the area of stenosis. And I'm not going to mention the results or anything because I think the stent is being the results are being reviewed these days. But this is what this stent looks like. It's tapered. It has a larger end for the sigmoid sinus and the smaller diameter for the transverse sinus, and it's large open cells, and importantly long enough to cover the entire transverse and sigmoid venous sinuses, and it's easy to deliver through a small catheter and over like a 14 wire. So it's a big advancement compared to what we use today, and hopefully we'll be talking more about this soon.
Thank you, Athos. I just want to add again that this stent is not FDA approved yet.
Correct. And a clinical trial was done and the results are being reviewed, and that's all we're saying. The patient selection, I think it's another important thing, and that's what I alluded to proposed title of Are You Over-Treating or Under-Treating patients? And I think that what I see is that, I think what we all see is that there is a lot of room to increase awareness and physician education about patients who will benefit from stenting. We still see patients that even in large metropolitan centers with academic hospitals and access to the latest information and et cetera, patients that are not offered stenting and they are offered shunt without the stenting being discussed. There are neurologists who still don't believe in this. There are neuro-ophthalmologists who are still skeptical. And I think we have, as a society and as individuals, we have a lot of room to increase awareness of this procedure in the patients that we already know that this works very well. Fulminant IIH, patients with papilledema and vision loss, refractory to medical management, patients with high intracranial pressure headaches, refractory to medical management, and patients with debilitating pulsatile tinnitus. There's a lot of studies out there, a lot of good work that has been done from many different groups that shows that these patients benefit from venous stenting much better than anything else. And we have to promote this. We have to educate our colleagues. We have to do everything we can to make sure that this treatment is offered to as many patients in these groups as possible. So I still think that in this category of patients, we are still under-treating with venous sinus stenting. Again, New York might be different than Dallas and maybe different than Indianapolis, but and I chose this like randomly. But my point is that there is still a lot of convincing to do for patients that we know based on good evidence from multiple studies that venous stenting will help them. On the other hand, I think what at least I see from patients with second opinions and third opinions, et cetera, is that stenting is often offered for symptoms that we are not sure that we're treating correctly. I don't want to get into too much details because I think I'll wait for the Q&A for that. But we should offer this exceptionally only when for things that we don't have or for indications that are not well studied and not well proven. And that goes back to the comment I made earlier. Having venous stenosis does not mean that requires venous stenting. Nothing bad can happen to a patient with venous stenosis that has no symptoms overnight. Patients can be followed, can be monitored, can be treated when things get worse, and they need to hear that. They should not hear that, oh, you have venous stenosis and you have to fix this because 10 years later you may develop IIH. So these things that I see more and more, and I think we're not offering good service to our patients when we have this approach. And so there's an element of over-treatment that is small, but I think it's getting a little larger. And we have to be careful as a society and individuals about this. There's certainly more work to be done to show new indications, to show that this is the best surgical treatment, and to show that in certain cases, I think this is even better than medical management for these chronic patients that are being treated with Diamox for years without necessary resolution of symptoms. The symptoms are under control, but patients have side effects from Diamox or Topamax or methazolamide or whatever medications they take. These patients would probably benefit from stenting if they have intolerance to medications. And that, I think, something we have to promote also with our colleagues and in our hospitals. Stenting versus shunting, I think sounds like a great study, and there are a couple of efforts, one in England, one in the United States. I think, I'm not sure if the Barrow study is still recruiting, but it's a very difficult study to tell a patient that you are eligible for stenting, but it will randomize you between stenting and shunting. I think that's very difficult study to be done, but it's possible, and if it's done, it will show I think good outcomes for stenting. We need new stents designed for IIH, stents for pulsatile tinnitus, that will improve outcomes for our patients and help us make this treatment even safer and more simple. And I think there's a lot of room for stenting for patients with chronic headaches that are not typical for IIH, but it seems that certain migraine syndromes or chronic headache syndromes could be related to venous stenosis. And again, I'm not saying by any means that everybody with migraine should have venous stenting, but there is a group of patients that we need to identify accurately, and hopefully in the next few years. Certainly, this is a study that we're looking to start soon in our system. We're looking into identifying another group of patients that would benefit from stenting down the road. And I think there's room for venous sinus thrombosis to be treated with stenting, acute or subacute or chronic. And certainly what we need is, and the patient groups need to help us here, is the, fight the insurance companies, because we're like at a constant battle here about getting approvals and hearing that this is a non-indicated procedure and it's an experimental procedure and et cetera, et cetera. So these are the things we have to focus in the next few years, in my opinion. And I believe this is my last slide. Yeah.
I have thank you, Athos. That was great. Really a very nice summary. I have a question from the audience that is basic but very important. Why do you need a stent? Can't you do just an angioplasty? I mean, a balloon angioplasty. The
short answer is no. The angioplasty might help in cases where you want to, it's very severe narrowing, like a stiff narrowing from like a chronic thrombosis, a calcified granulation, something that is does not allow easy access for our catheter system. But angioplasty alone as a treatment will not work, because it's almost certain that the moment the balloon is deflated, the sinus will recoil back into the narrowed state. And I've seen that. I've looked into this early on. Early on means many years ago, and that is not a viable option.
About the balloon, I have a question that's a personal question, because many physicians have asked me this question. When you have a very, very protrusive arachnoid granulation, and for example, it's partially calcified, or you suspect that you are going to need a balloon angioplasty, would you do a balloon angioplasty first and then place the stent? Or would you place the stent and do the balloon angioplasty only if there is still a residual gradient?
My approach is to do it only after stenting, is if there is residual stenosis or residual gradient. I do often use a balloon to navigate, in these cases where it's stiff stenosis, high grade, there is no room to advance, our catheter systems through. But I don't do this to open up the sinus so much, that to facilitate the stent is to facilitate our, navigating through the area of stenosis. So I think I understood your question correctly. I would angioplasty post-stenting if needed.
Okay, I think that was a fair answer. So we have 5 minutes. I wonder if we should open the can of worm that is chronic headaches with without typical IIH. So I suppose that you have a patient with a lot of headaches. She's a young woman, likely overweight, and you suspect IIH. I mean, you suspect that her headaches might be, might be an atypical IIH. How would you explore this patient?
I think there is I think the first step that may give you like a good answer is a lumbar puncture. Because if the patient doesn't necessarily need to have high intracranial pressure. It could be, it could be like a borderline pressure, it could be like in the 20s or 27 or 19, whatever it is. It's more important to see how the patient responds after the spinal tap. And if the patient improves after the spinal tap, even for a day or two, I think that's a strong indication that you will help by normalizing intracranial pressure. And I think, and that's one way to see this. Even though there is some literature that says that the response after intracranial pressure does not predict headache improvement after shunting, I believe there was a specific study. The reality is that you have to have a conversation with the patient, and I usually do these spinal taps myself. So I tell the patient, you have to think about this, keep a diary, the first 5 hours, the first evening, the next day. Because if you tell a patient, did you feel better after the spinal tap? And they say, no, actually it was worse. I say, what do you mean? Well, my usual headaches went away, but then I had worse headaches. I couldn't get out of bed, etc. So, you have to discuss what the patient means. It got better or not. And I think often, if you go into the details, you realize that the patients had some improvement of the chronic headaches from high pressure, even if the spinal tap, the opening pressure wasn't like as it would qualify, for IIH. So I think that's easy. If you have that, I think it's reasonable to proceed with stenting, and there has a high likelihood of helping. Then the other group is that, and I will admit that, I had difficulty making that decision many times, is that there is no improvement after spinal tap. There is no, the pressure is not high. It's not going to be 10 or 12, but it's going to be 19, 20 something, maybe 25. But they do have severe stenosis and a significant gradient. And these patients I had a long discussion with, and I hesitated, and many times, I wouldn't say many times, but there's a few patients that I remember very well that made me very humble, because they insisted that they want to try this because they tried everything else and nothing worked, and it helped them. But others it didn't. So it's not like 100%, but I think that's a discussion between, if you don't have improvement after lumbar puncture, if there is a good gradient, I'm not talking about 8, 9, I'm talking about 15, 18, a significant gradient. Some venous stasis on the venogram at the area of stenosis. I think these patients are reasonable to consider stenting with the understanding that it's you cannot make any promises. So
there are two more questions from the audience. One is the stent reversible? The answer is no. But there is another question that is really difficult to answer, is that that some people go into remission with IH. So the disease will last, let's say, 10, sometime 10, 15 years. And then they will go into remission. The papilledema will go away with medical treatment. However, they will be left with chronic headaches. So knowing that the disease can go into remission, does this change your indication?
No, it doesn't, because I think we cannot predict when the patient will go in remission. I think it goes back to how you approach this disease and these patients. It goes back to, should we offer stenting because somebody has 70% stenosis on MRV or AD or whatever it is? Or should we make a decision based on symptoms, response to medical management, and quality of life? And I think at the time where you make this decision, you have to factor primarily the symptoms, not the presence of stenosis. And somebody may have stenosis and may never develop any significant symptom. Another person may have stenosis with mild symptoms and months, years later, develop the full spectrum of IIH. So I think it's difficult to predict who will go in remission without treatment. So I think you have to stick to, at least personally, I would stick to what I have been saying the last hour.
So we have 1 minute. I mean, we have to conclude. I mean, so am I right in saying that, in your opinion, without considering the possibility of remission, patients should have a surgical intervention, and in your practice, preferentially a stent, when they have symptoms of venous sinus stenosis that are resistant to medical therapy, or patients who do not tolerate medical therapy? Would that be kind of general conclusion?
That would be the general conclusion, with the asterisk of fulminant presentation, which is very rare, but then you have to go up front with the surgical treatments.
As an emergency.
As an emergency, yeah. That's rare, of course. Yeah.
To save vision. Yeah.
Correct. Yeah.
Very good.
Okay. It was a pleasure. And
our host at IH Hub want to conclude. No?
Maybe not.
We are fine. Thank you, Athos. Thank you, everyone who attended and who asked those very interesting questions. Goodbye.
Take care. Bye-bye.
I don't see the final slide. But yes, thank you everyone for coming and for your participation in the chat. If you have any further questions that we didn't address, please feel free to send us an email through the website, and we'll make sure to pass it to Dr. Gobin and Dr. Patsalides. And we hope to see you at our next webinar, which will be in September. We're going to pass on August because it's vacation time in summer. So we will return in September and place that on our social media platforms and website to let you know the exact date and time. But it will be with Dr. Bobby Stark from the University of Miami, and he will be discussing a topic related to IIH.
Thank you, Edith.
Thank you for your time. It was a wonderful presentation.